Hello everyone, welcome to my channel. In today's video, we're going to simplify anemia. Anemia is defined by low hemoglobin levels, lower than 13 gram per deciliters in males, 12 in females, and 10.5 in pregnancy. What is hemoglobin? Hemoglobin is a protein that contains 2 alpha and 2 beta chains containing hemes, which contains iron. The iron binds the oxygen and carbon dioxide. There are many hemoglobin proteins in the red blood cell, which itself is a nucleus, meaning it doesn't have a nucleus to contain more hemoglobin. A quick recap regarding the production of the red blood cell. The red blood cell, or erythrocyte, is made through a process called erythropoiesis, which happens in the bone marrow. When there is low oxygen level, the kidneys release a hormone called erythropoietin. This hormone stimulates erythropoiesis, which happens in the bone marrow, from hematopoietic stem cell to erythroblast to a reticulocyte. The reticulocytes leave the bone marrow to the vessels and becomes a full emitter red blood cell in 1 till 3 days. The red blood cell survives in the blood circulation for 120 days, then gets eliminated by the spleen, the liver, and the bone marrow. This process is called hemolysis. Now, just what is the role of the red blood cell? These cells are in charge of transporting the oxygen from the lungs to the tissues and transporting carbon dioxide from the tissues to the lungs. Now that we understand what the hemoglobin is, how the red blood cells are made, and why they're important, let's see how to detect anemia in a patient, starting with clinical findings. The patient often presents with pale skin. The lack of the hemoglobin causes the skin to appear paler since it gives blood its red color. Shortness of breath as the lungs try to release more oxygen. Rapid heartbeat is a sign of the heart trying to pump more blood. Fatigue, especially during activity. Dizziness, and in severe cases, it can lead to fainting due to a lack of oxygen to the brain. Other symptoms depend on the cause. For example, in vitamin B12 deficiency, we can have neuroanemic syndrome made of neurological symptoms. We have Hunter glossitis, it's a smooth red tongue, which we'll detail in another video. In iron deficiency, we have koilonychia, it's spoon-shaped nails. We also have brittle nails, as in they crack easily, hair loss. We can even have a rare condition called pica syndrome, where the patient consumes non-edible items such as hair. So, as you noticed, you can suspect anemia from clinical examination. However, to confirm the diagnosis, you'd need a very simple blood test that you demand on daily basis, which is the full blood count. If the patient has anemia, you'll see low hemoglobin level. Now, after diagnosing anemia, you'll need to classify it, as treatment depends on which type of anemia you have. In this video, we'll have an overview of classification, then we'll detail each type in the next video. It's extremely important because anemia is a symptom, as in it's due to a cause. You need to know the cause in order to treat it. So, low hemoglobin, what next? MCV, or mean corpuscular volume, which reflects the size of the red blood cell. If it's lower than 80 centiliter, it's microcytic anemia. If it's between 80 to 100, which is the normal value, it's normocytic anemia. If it's above 100, it's macrocytic anemia. Starting with microcytic anemia. First, you'll need to check serum iron. If it's low, continue with ferritin. To distinguish between anemia of chronic disease, which has normal or a high level of ferritin, it means all diseases that cause chronic inflammation, such as neoplastic, chronic infections, lupus, rheumatoid arthritis. We'll explain how these type of diseases cause anemia in a detailed video. And between iron deficiency anemia, which has low levels of ferritin. If, on the other hand, iron serum is normal or high, think of beta thalassemia. In erythropoiesis, we'll find abnormal hemoglobin types with low HbA and an increase in HbA and HbA2 where it's supposed to be the opposite. If electrophoresis is normal, continue with bone marrow aspiration, as it could be sideroblastic anemia, alpha thalassemia, which might need further genetic testing. And that's how you approach a patient with low hemoglobin and low MCV. Moving on to normal and macrocytic anemia. In these types of anemia, the first thing you will need to check is reticulocyte count to see if the bone marrow is producing red blood cells accordingly in response to the body's need of oxygen. If it's increased, it means the bone marrow is healthy. It's what we call regenerative anemia. Here, the anemia could either be due to blood loss or hemolysis. To know the difference between the two, in hemolysis, you'll find an increase in LDH level, as the destroyed red blood cell is going to release LDH to the blood circulation. You'll also find an increase in the indirect bilirubin due to a heme breakdown. And you'll find a decrease in haptoglobin since it's going to bind to the hemoglobin released by the destroyed red blood cell. LDH, indirect bilirubin, and haptoglobin are going to be normal in blood loss. Examples of blood loss we have trauma or surgery, for example. For hemolysis, it could either be corpuscular, meaning the defect is within the red blood cell, or extracorpuscular, meaning the destruction of the red blood cell is due to external factors. Corpuscular could either be congenital, for example, abnormal hemoglobin in thalassemia or sickle cell anemia, membrane defects in spherocytosis, or enzyme defect, for example, G6PD deficiency, known as favism. So we said that it could be congenital, it could also be acquired, for example, paroxystic nocturnal hemoglobinuria, where the complement system attacks the red blood cell due to a gene mutation that's acquired during the person's lifetime. In extracorpuscular anemia, check the Coombs test to see if it's immune. For example, in autoimmune hemolytic anemia, if it's negative, it can be due to protistic heart valve or infection. Now, for non-regenerative anemia, the bone marrow can't produce enough red blood cells. In normocytic anemia, the first thing you'll need to check is the bone marrow. If the bone marrow is normal, the anemia could be due to kidney disease from low erythropoietin, since it's the hormone that stimulates the production of red blood cells, or liver disease from chronic inflammation or from low erythropoietin. It could be anemia of chronic disease, since in inflammation it's first normocytic, then it becomes microcytic, or hypothyroidism from a decrease in tissue consumption of the oxygen, or even weakening in the lungs muscles causing low oxygen intake. If the bone marrow is abnormal, it can be due to infiltration, for example, by leukemia or metastasis, or aplastic. Non-regenerative macrocytic anemia could either be megaloblastic or non-megaloblastic. In megaloblastic anemia, we have an abnormally large red blood cell from impair in DNA synthesis from vitamin B12 deficiency or B9 deficiency. In non-megaloblastic, we have large red blood cell from other conditions such as alcoholism, direct toxicity on the bone marrow or low vitamins causing megaloblastic, or liver disease from defects in membrane structure. So to recap, if the MCV is between 80 till 100 or above 100, the first thing you'll need to check is reticulocyte count. If it's regenerative, either blood loss or hemolysis. To know the difference, check LDH, which is elevated, and direct bilirubin, also elevated, and haptoglobin will be low in hemolysis. If it's non-regenerative and MCV is between 80 till 100, check the bone marrow. If it's above 100, it could either be megaloblastic from B12 or B9 deficiency or non-megaloblastic. And that's an overview on how to approach a patient with low hemoglobin. We'll detail each type in the next videos. Make sure to like and hit the subscribe button. Thank you so much for watching.